Good morning, and thank you for the privilege of being here. Dr. Kellerman, I'm fired up. Appreciate the intro because it's a great segue to my talk as well. These are the simple things that Dr. Kellerman said EMS agencies, and by the way, emergency departments and ICUs could also do, with the exception of working it at the scene, I guess. But it's not being done. The science is good, the practice is not so good. I'm going to talk a little bit about why I think that is, why dissemination of best practices, implementation of best practices are complex and difficult in our United States EMS system, and how we can incentivize EMS agencies to do better with the basics and to be proud of the work they're doing by getting better. 21,000 EMS agencies licensed in the United States. I did a little lecture in Israel a few years ago that has one EMS system, and the main question that was asked to me is, how the heck do you organize a system with all those different agencies? It's a darn good question. And I said, actually, we do a pretty good job. But we have so many different types of EMS agencies, each of which has been created to meet the needs of its individual community, with its individual fire chiefs and individual dispatch folks, and the county council owns a piece of it, and everybody gets to be sort of a piece of their own little fiefdom. And then they serve their community, many of which are volunteer agencies in rural environments that work literally on a shoestring. So putting all these pieces together is complex, and there have been efforts to actually begin the development of national standards. The Institute of Medicine's landmark EMS at the Crossroads document really set a strategic template that was followed by visionary leaders such as Mr. Dawson, who's on the stage with me here. The NHTSA Office of EMS developed the National Scope of Practice documents. HRSA EMS for Children program has been very active in making sure kids aren't left out of EMS policies, equipment, and protocols, and continues to do so. NASEMSO, the organization I'm here representing today, National Association of State EMS Officials, is the group of all the EMS offices. EMS is actually completely and wholly regulated at the state level by design. So all these folks get together regularly, and one of the things they did with the support of NHTSA was develop national EMS model guidelines, which were published a few years ago. These are field treatment guidelines that agencies can utilize to develop their own treatment protocols and bring more consistency to EMS care across the country. The National Registry of EMTs has developed EMT certifications that are standards. The COAMPS, I know this is kind of alphabet soup, and I apologize. This Committee on Accreditation of EMS Programs has National Paramedic Program Training Standards and Certifications. And then we've developed, actually, finally, little nibs of EMS research, and more because of devoted medical directors and devoted paramedics in the field who become more and more academically minded. We're developing a research base which is helping us put together evidence-based practice in the field. Really important. And lastly, a big deal was the American Board of Emergency Medicine, the ABMS. First of all, the American Board of Medical Specialties authorized EMS to become an official subspecialty of the field of emergency medicine, which was a big step forward in encouraging emergency physicians who graduate and have an interest in EMS to become board certified, do a fellowship, and become experts in their field and leaders in their communities. So we've had a lot of efforts towards improving national standards, getting more consistency in the care that's provided in the field. So now we have to say we have these standards. We have the 4 things that Dr. Kellerman said make a difference when we focus on cardiac arrest. We need to look at a couple of things. Number 1 is process outcomes, performance measures that say, are you doing a rate of 100 to 120? Are you compressing deep enough? What's your rate of community bystander CPR? Processes. And ultimately, these processes, as they're implemented, help, we hope, improve outcomes, but that needs to be measured as well. The CARES registry is an outstanding example of managing to connect the EMS record to the hospital outcomes. No small undertaking, trust me, we do it in my state. But it's important. So we have process measures and outcome measures. And I would argue that we need to do something with performance improvement in EMS and in hospital cardiac arrest care. I don't think we should try and bite the whole elephant. I think taking a piece at a time makes sense. Let's get agencies to sort of understand performance improvement. And again, thanks to NHTSA, NASEMSO has an ongoing project currently to establish a method for developing performance measures for EMS in the field, for cardiac arrest, for trauma, for STEMI, for multiple things, including some safety measures, EMS and provider safety, as well as patient safety. Their tasks are not only to develop a model process for the development of performance measures, but also to put together a group of performance measures that are starters for agencies. So here's the proposed EMS Compass cardiac arrest performance measures. These measures are currently in development. This is new news, relatively. They recently went through a development process, a review of the evidence to make them as evidence-based as possible, then a public comment period, and now they're out to be tested by vendors. The idea is to make vendor simplicity so that as EMS agencies adopt this or that electronic patient care record system, there'll be a little tab that says PI or PI today, or how am I doing today, or this week or this month. And with a couple of clicks, they can see any of these items. Now, to try and do all of these items is eating the whole elephant and probably not a great idea. But if we can start with some really, really simple ones and make agencies aware, individual paramedics aware of their performance, that drives improvement. Whether it's the Hawthorne effect, which I'm crazy about as well, or the fact that paramedics are inherently competitive animals and they love to do better than the guy next to them or the agency in the next city. It doesn't matter. By starting performance improvement like this in EMS, we can, I'm convinced, improve care. Again, measure and improve. So I was asked to do challenges and opportunities. We'll start with the opportunities. That's to develop this culture of excellence, and that's a real broad sort of great concept idea. What that means to me is to make the medics care. They always care about the patients, but they don't really get much in the way of feedback or outcomes. So make them care that last year, 15% of their VFib arrests actually walked out of the hospital. This year, it's 18%. Can we make it 25? Develop that culture of excellence to actually look back at how did I do, and can I do it better next time? I also feel like future evidence-based guidelines published should use the model process developed by NASEMSO to be accompanied by performance measures. So if we're going to have this technique for endotracheal intubation, because it's evidence-based, here's some ways we can measure that we're doing it right. Challenges are incentivizing, bottom line, this comes down to funding as things do, incentivizing agencies to do this. This takes work, this takes people to collect data, this takes looking at stuff, which takes FTEs, which takes money. Bottom line is, can we require it? Is it an unfunded mandate? Is good quality patient care, including performance improvement, an unfunded mandate? I don't think so, but we have to be aware that these agencies have very limited resources, and more asks cost money. And that means they don't get a new ambulance or that end-tidal CO2 monitor they wanted, et cetera. So the state offices, just to finish, may have a role in this, potentially incentivizing EMS by doing things like saying, well, prove you're doing some kind of performance improvement, or you can't do we won't relicense you next year. Certainly funding, reimbursement could be put into this, but I'd rather make it a positive than a punitive thing if possible. So I'm a big fan of performance improvement, looking at how we're doing, measuring and improving, and thank you very much.